So today's class is on schizophrenia. So let us start with it. Schizophrenia and other psychotic disorder. This class will be outlined in introduction, epidemiology, diagnosis, types, and Smita, you have written that you are not audible. So in the end, you need to go to the microphone option and try to make yourself audible over there. There is some option over there. You need to work on that on the left side. You need to click if you are on a mobile phone, call from dialer, it will come up and it will be audible to you. Okay. Don't scribble anything, annotate, don't use it. Mute yourself, please. Your voice is disturbing to all. Okay, coming to the first slide. Introduction. History of schizophrenia. We need to understand how the schizophrenia came into existence. Benedict Morel in 1852, he used the term dementia precoce, in which the young patients started developing, having the symptoms of mannerism. They started neglecting themselves. Later on, Emil Kraepelin used the term dementia precox, where he classified different forms of schizophrenia, and it explained in very well. Eugen Bleuler is the person who coined the term schizophrenia per se. Sometimes in MCQs they ask that who coined schizophrenia. Eugen Bleuler is the one who coined schizophrenia. I ask all the participants to keep your pen and a book ready so that you can make the notes if you want. There are 4 A's of Bleuler, which is very important. One is abnormal association of thoughts, the affective abnormalities, ambivalence, and autism. These are the 4 ways of Bleuler. The ambivalence, the word itself means that 2 conflicting thoughts are coming into a mind of a person against his or her own wish, like to pick the watch or to not pick the watch, or to enter the room or not to enter the room. So these are the 2 conflicting thoughts the person gets at a given point of time, which is called as ambivalence, seen in schizophrenic patient. The autism means the patient who has a schizophrenia, he stays aloof, shells up is in his own self, doesn't interact with other. The affective changes means, affect means expression of internal emotions, where the patient starts smiling, giggling, roaming around, and those all things can be seen. The thoughts are not associated with each other. Again, some people are chatting over here that they are not audible. You please go to your extreme left side where there is a mic icon. Press on that. You will get a call dialer. So you just press on that via dialer, call via dialer, then you will be audible. I will be audible to you. So continuing the class. So Bleuler's association disturbances or loosening of association, what we say, where these patients' thoughts are not linked to each other, where the patient's one thought and other thought are not in cognizance to each other. Like the patient starts talking that my father is not well, and then he shifts to how is your mobile phone, then I have a headache, what was in the breakfast, is everything all right with you, what about this room, why this is dark. So these all things they start asking. So the thing is that over here we need to know that loosening of associations are very important. So the 4 A's of Bleuler of association is lost in between thoughts, affect is abnormal, ambivalent, and autism. Next, coming to Snyder. Snyder explained the first-rank symptoms of schizophrenia, which we'll talk in the further discussion. Sands and Langs in 1960 onwards, he explained about in a view of biopolitical intervention. Crow and other things also explained in different ways, biological and biosocial model, which we'll be discussing in future slides. Coming to the first rank symptoms of schizophrenia, which we all need to know. The first one is amylcripline and Bleuler, which I told you in the same thing, which has been explained to you, 4 A's of Bleuler and Treplins. These are the first rank symptoms which are asked in your MCQs and your question papers. The first one is a delusion, which is primary in nature, which is called as delusional perception. The delusional perception word itself means that the patient has delusional interpretation to the perception what he is getting. First, let us understand what does this delusion means. Delusion means that this is a false, firm, fixed, unshakable belief apart from person's socio-cultural and educational background, causing significant distress, even after explanation on the contrary. So that means that the person has a belief that someone has plotted a camera in my room and he's surveillance and keeping surveillance on me 24/7. The person has delusion of persecution over here. This belief is false. No one has placed a camera in his room. But even after explanation on the contrary, the patients, they firmly believe that there is a camera. You just tell him that kuch bhi nahi hai yahan pe, nothing is around, everything is clear, no camera is seen. Yet the patient firmly believes that there is a camera in the room. So that is false, firm, fixed, unshakable belief. One important part of delusion is it should be away from the person's socio-cultural background. That is a part of the definition. Here the patient's socio-cultural beliefs are not considered to be delusion. If the person believes that in Navratri Puja, the person gets a ghost or a goddess in him and starts chanting, the 100 people are there in that puja, believes that that person has a possession of goddess, they are not deluded, even though that is false and firm. In delusional perception, in schizophrenia, here the person clearly believes that a perception which is normal, yet a false belief is attached to it. Like for example, someone is entering into the room. This person believes that if he is delusional and has a perceptual delusion, he believes that that person is against him and has something in his hand or in his pocket and trying to catch him, hold him, kill him, or record the conversation between them. So a normal perception of a person entering into the room is attached with a delusional meaning. That's what delusional perception says. The second first rank symptom is auditory hallucinations. The hallucination per se means that false perception in absence of external stimuli. There is no external stimuli, yet the person perceives there is something. Here in auditory hallucination, the person perceives that someone is talking to him or some noises and voices are coming, even there is no one around him. So that is auditory hallucination. Here, in schizophrenia's first rank symptoms, there are 3 types of auditory hallucinations Snyder explains. First person, second person, and third person. The first person auditory hallucination is, here the patient says that I hear my own thoughts aloud. So my own thoughts are heard to me. In second person, the person says that someone is talking to me. One voice or a noise is coming to me. I'm hearing that noises and voices. A second person can be in the form of running commentary, like the voices may be commenting on the actions of the person and sometimes commanding in nature. The voices may say that you have to do this, you have to jump from here, you have to hit someone, or do not eat, or whatever it may be. The third person auditory hallucination says that they are talking between themselves. So 2 to 3 people are talking between themselves and about the patient per se. So that is the second auditory hallucination symptoms of Snyder's first rank symptoms. The next one is thought alienation phenomenon, what we see. In the thought alienation phenomenon, what happens is the patient says that he has thought withdrawal, thought insertion, and thought broadcasting. That means the patient has something called as thought insertion. The patient says that someone is inserting his own thoughts to his mind and the patient appears completely blank. That is thought insertion. At the same point of time, the patient may communicate that someone is taking his thoughts out of his mind. At the same point of time, the patient may appear blank also. So that is thought withdrawal. Sometimes some patient do comment that his thoughts are broadcasted in different platforms. Like they may say that in thought broadcasting, the patient says that my thoughts are being heard to others who is in front of me, or my thoughts are being communicated in the form of television, radio, or in the newspaper or something else. So that is thought broadcasting. Then comes a made phenomenon of first rank symptom of schizophrenia, which explains that made affect, made impulse, and made violation. These are the three things which you see. So the patient says that someone is making me laugh, that is affect, or making me cry. I am not doing it. Made impulse is the patient gets an impulse to do certain act. Like if the person goes to a cremation ceremony, for example, he laughs. That means made affect. Someone is making him laugh. He says and communicates that I am not laughing. Someone has controlling on me and they are making me laugh. That is made affect. Made impulse is something that the patient communicates that I get an impulse of trying to test whether the person who is dead over there is really dead by stabbing him. I know it's not required, and someone is making me to do that, or impulsively coming the thoughts in my mind. So that is impulse. Made violation is the patient acts out on those impulses. He may literally go and touch the dead body and try to stab or try to make him wake up. And when asked, the patient says that I'm not doing it, someone is making me do that. So that is made violation. The last one is somatic passivity. Here the patient says that someone is passively moving my own body or touching me, which I don't like it, and I'm not having control on it. So that is somatic passivity, which is seen in schizophrenia first prime symptoms. Now let us revise ourselves. What are the first rank symptoms of schizophrenia? The first is delusional perception. The second is auditory hallucination, in which first person, second person, and third person auditory hallucinations are seen. The next is thought alienation phenomenon, in which you have thought insertion, thought withdrawal, and thought broadcasting. Am I audible? The next is made phenomenon, where you have made affect, made impulse, and made violation. And the last one, fifth one, is somatic passivity. This is very important. I want you people to understand first rank symptoms of schizophrenia. Coming to the next slide. Please don't scribble on the slides. Don't use annotate. It will be difficult for you to understand what has been written on the slides. Okay. Now let us understand what our classification says. Okay. Schizophrenia and other psychotic disorder is the classification in DSM-5 and ICD-10. The first one is schizophrenia per se. There are different types: paranoid, disorganized, catatonic, undifferentiated, and residual type. There is next classification or next disorder in psychotic disorder group, which is called as schizophreniform disorder. The next one is schizoaffective disorder, delusional disorder, brief psychotic, shared psychotic, psychotic disorder due to general medical condition. GMC means general medical condition with delusions, with hallucination. In that, you also get substance-induced psychotic disorder. You know the patient is psychotic, but you are not able to put in one category. You classify it as psychotic disorder, not otherwise specified, NOS category. So these are the classification of psychotic disorder. We'll come to each one of them in future. Coming to epidemiology, the most important lifetime risk and prevalence is around 1%. That means out of 100 people, one will develop schizophrenia in his lifetime. Okay, that is quite huge. Annual incidence is 0.02, equal in both sexes. But what they say is in females, it starts a bit later, that is 25 to 35 years median age of onset. In males, the onset is earlier, 15 to 25 years. It is rarely seen below 17 and above 45 years. That means you need to understand that if the patient comes with psychosis beyond 45 years, don't jump and diagnose the patient as schizophrenia. There may be other reasons to have psychosis. Remember, all schizophrenics are psychotics, but all psychotics are not schizophrenic. That is very important. We all need to know. About the epidemiological things which you need to know here are winter births. Excessive, the patients who are born in the winters are more likely to develop schizophrenia. Some of the studies do say that. It may be because of neurodevelopmental insult occurring when the patients are in the womb of a mother during the second trimester. Some amount of viral infection or torch infection hinders the development of the brain or the limbic system during the development in the womb. And these patients, during the second stage of the lifetime, where the pubertal burst occurs during 15 or 20 years of age group, they develop the symptoms of schizophrenia. Some of the studies do say that. Family risk of schizophrenia is there. The means there is a hereditary, which you need to know that. Early neurological insult is more common in these patients. 10% of these patients are likely to die because of suicide. Someone is asking some question related to somatic passivity. I will come back to your question and answers. We'll talk about it later. Just let me complete with the talk. Okay? Don't worry, we will address the questions. Maintaining factors is very important. The word high expressed emotions we all need to know. If the patient who is more likely to develop schizophrenia or psychosis, or the patient who is diagnosed with psychosis or any other psychiatric illness, if their family members have high expressed emotions in their family, more likely that these patients will develop relapses. The expressed emotions are hostility. That means they are hostile towards the patient. You are mad, you don't have any comments, and they become violent towards patient. तेरे को कुछ नहीं होता है, तू ऐसा ही है, मरते दम तक ऐसा ही रहेगा. These all things they talk. That is very bad on the part of the relatives, which we need to know. Critical comments. That means they are very much critical about the actions and the talks of the patient. That is also very bad. Emotional over-involvement and over-warmth. These two are very bad in terms of patients' relapses and the development of the disease. Like over-involvement in the terms of that you don't eat food, I will prepare for you. You just sit at one place, or showing over warmth. खाना भी हमें खिलाएंगे, पानी भी हमें पिलाएंगे, सामान भी हमें ला के देंगे, कुछ भी गलती करे तो हम बंद करके रखेंगे. No one will talk or no one will abuse you. That is also bad. You need to explain the family members that high expressed emotions are bad and you need to train how to control it. The other maintaining factors important are non-compliant to the treatment and drug abuse. As I explained you, this is what is the age distribution which I told earlier in males and later in females. So what are the features of schizophrenia? It affects all the domains. First, coming to positive symptoms of schizophrenia, delusions and hallucination. The first more important thing are delusion, which I explained you. Delusion of persecution is commonly seen in schizophrenics. Hallucination, auditory form of hallucinations are commonly seen, as I explained in first rank symptoms of schizophrenia. Coming to the next one over here, disorganized speech or behavior. The speech is not organized. As the Bleuler told, loosening of association is commonly seen, where one thoughts are not connected to other. I told you with example earlier. If the loosening is severe enough, it appears as if single words are coming up. It's called as word salad. Like the patient tells, Sar dard, khana, pani, mobile, pet mein, mummy, ghar. They are not completing the sentences. And the word output, it appears as if a speech salad or a word salad. Okay. And sometimes in disorganized speech, you also get neologism. The neologism word itself means that new words are invented by the patient which give a newer meaning for them, or else an old word with a new meaning. Like one of the patient used to say, tick, tick. When he says, it means that I'm not interested to talk to you. You are very rude to me. Please go out of the room. If someone doesn't listen that, he used to become very aggressive. So this is neologism in schizophrenia. Some of the disorganized behavior can be smiling infrequently. They laugh, they smile out, they shout, they yell. They start collecting garbages, which is a part of disorganized schizophrenia, where you see many people roaming on streets, smiling, giggling, mirror gazing, okay, standing aloof, collecting garbages. No one likes to do that, even though how much poor they are or beggar they are. Okay, disheveled. They don't wear the dress properly, maybe half naked or something like that. Either they have schizophrenia, either mental retardation or some other psychiatric illness. In schizophrenia, disorganized behaviors are seen in this way. Even in schizophrenia, you do get, look, we do have 10 minutes of time. I will try to log in again after once we finish it so that we continue with the class, okay? And I will send you the link again. As it is a free version, you need to re-log in again, okay? Let us try out this also. Continuing with the class, mood symptoms. The mood symptoms are depression, anxiety, aggression, and hostility are commonly seen along with suicidal behavior and thoughts. Negative symptoms are commonly seen. Anhedonia, which is classically seen in depression and seen in schizophrenia also. The word anhedonia means that lack of interest or pleasure out of previous pleasurable activity. Previously, the patient used to enjoy cooking, talking with friends and family member, going out to the party, but now he is not getting pleasure out of it. There is something called as affective flattening, which is seen. What does this mean, affective flattening? That means the affect, that is the appearance of the patient is completely flattened. No expressions on the face can be seen. A violation itself means action. He is not doing any activities at all. That is a violation. Social withdrawal, that is very commonly seen in schizophrenia. They become asocial, so they don't interact with the family members or friends or anyone else. Alogia, the speech output itself reduces completely. They don't talk at all. So these are all the symptoms of negative symptoms of schizophrenia. Motivation is also there. The next is cognitive deficits. This is last thing to develop in schizophrenia. In the long chronic patients, attention impairment, they are not attentive in discussion and talks. Memory impairments are also seen. Executive functioning, like getting the task done, multiple tasks doing, or if you say the patient, you go outside, get a cup of get biscuits, then go to a mobile store, get a recharge done, then go to a bank and get your passbook updated and come back to home. Here, 3 functioning has to be done by the patient. This patient will not be able to do all the 3 together because of executive functioning, which is impaired in these patients. All these domains will lead to functional impairment in work and social life. Interpersonal relationships are impaired. Self-care becomes very poor. So these are the symptomatic dimensions of schizophrenia, where you get positive symptoms, disorganized symptoms, mood symptoms, negative symptoms, and cognitive symptoms leading to functional impairment. Coming to the next one, what are the criteria to diagnose schizophrenia? Out of 5 symptoms, 2 or more need to be present to diagnose for at least 1 month duration as per ICD. As per DSM, it should be present for more than 6 months. What are these 5 symptoms? Delusions, hallucinations, disorganized speech, disorganized or catatonic behavior, negative symptoms. Out of these 5, 2 or 2 to be present. Here a question comes. A patient can be schizophrenic even the patient doesn't have delusions and hallucinations together. That's very important. Okay? Here the patient has a disorganized speech and disorganized behavior, he can be schizophrenic. It is not must to diagnose schizophrenia that delusions and hallucinations should be present, but they are also very important in diagnosing of schizophrenia. The B criteria says that socio-occupational impairment or dysfunctions are seen. Duration, as I told, according to DSM, Diagnostic Statistical Manual, 5th edition or 4th edition, says 6 months is minimum required. ICD says 1 month is enough to diagnose the patient as schizophrenia. You have to rule out schizoaffective disorder and other mood disorder where the psychotic symptoms are present. That means you need to rule out other psychiatric primary diagnosis before you diagnose schizophrenia. E criteria says drug-induced general medical condition or substances and medications to be ruled out to diagnose as schizophrenia. That means everything needs to be ruled out, and the diagnosis of schizophrenia is a diagnosis of exclusion. If there is a drug induced like carbidopa, levodopa, the patient is taking and developing psychotic symptoms, that means it is drug induced psychosis, not schizophrenia diagnosis. Okay, that means you need to treat the patient or remove the offending agent or add an antipsychotic for a temporary period of time, but you should not make the person diagnosed as schizophrenia. The last F, you need to diagnose the patient schizophrenia with pervasive developmental disorder with caution. Okay, if the patient has delusion and hallucinations for persistent duration of time, you need to diagnose with caution in PDD. Pervasive developmental disorder is in childhood psychiatry. It is autism spectrum disorder. We need to know that also later. What are the course specifier? Usually psychotic or antipsychotic conditions have an episodic pattern. It may have interepisodic residual symptoms, or it may have interepisodic complete remission, full remission, or negative symptoms or worsening of symptoms. Okay, so these all things are specifiers which you can use it in diagnosing schizophrenia. So 15% of patients of total schizophrenics have single episode in their lifetime. 25% have a repeated episode and they come to the baseline inter-episodically. 30% have subtle impairment in between the episodes, but yet they have episodic pattern. Last one-third patients have progressive decline in functioning. Episodic with progressive decline can be seen. Delusions, I explained you, that is one of the positive symptoms of schizophrenia. Different types are seen. I won't go into details about it. Hallucination, I told you, auditory is one thing which is seen in schizophrenia. Other domains of hallucinations are not seen commonly in schizophrenia. Disorganized speech, I explained about this. Losing of association, frequent derailment, clangs, neologism, tangentiality. There is something called a tangentiality where you ask some question, the patient appears that he will come to your answer, but yet go tangentially away from the question. So can be seen in schizophrenia. This is how we explain question and answer is normal, goal-directed, linear kind of a thought. Tangential, he will not come to your answer. Circumlocation or circumstantial, he will tell all nonsense in between, but yet answer your question. You ask a question what you had in your breakfast, the patient start telling that I had a good sleep in the night. In the morning, I wake up at around 7. I was very drowsy. I pushed myself to go to the bathroom. I freshened up. Then I took again a nap of 5 to 10 minutes. Then I took a bath. Then I went to the drawing room, saw the TV, and I was seeing mobile phone and checking something. Then again, my wife came. She asked for a breakfast. She gave me a bread toast and a tea. I had that. So I don't want those many answers. My question was straightforward. He would have told bread toast with the tea. But yet he answered many things in between. That is circumstantial speech. Can be seen in schizophrenics, can be seen in obsessive compulsive personality, even in bipolar manic patient. This is loosening of association, which is explained. Two thoughts are not linked to each other. The patient eats up the in-between thought process. That is loosening of association. Incoherence, you ask question, the patient answers, but differently. He doesn't come to the point at all. Behavioral changes are, these are the different behaviors we need to know. Childlike silly smile is seen. Unpredictable agitation. Disheveled means very bad appearance, not taking bath for months together, not combing hairs. Inappropriate sexual behavior can be seen in some of the patients. Catatonic behavior is very important. Here the patient appears completely mute and stuporous. He doesn't move at all, maintaining odd posture for a prolonged period of time. The patient maintains that posture like psychological pillow, sleeps on a bed as if there is a pillow beneath